For the invitation. I will try to answer the question in the next 5 minutes. So the brief answer is yes, but the crucial point is how, because we can do it, but it has to be feasible, as we saw in the case. So I will try to make 3 very short points. The first one is, do we have data about physiology in a complex PCI setting? The answer is yes and no. We have preliminary studies. This is the Aqua 2 trial that we published in JACC Intervention and presented at TCT last year, and we basically randomized patients to either a conventional angiography-based PCI or a physiology-based PCI in patients with complex criteria for PCI. And we tried to understand whether this was possible either with angiography-derived FFR or microcatheter-derived FFR. So as you can see, what we did was to plan PCI according to the physiology pullback, either angio-derived FFR or microcatheter measured FFR. The primary endpoint was post-PCI FFR, and basically these are examples on how it was done. The primary endpoint was reached in terms of the probability to obtain an optimal post-PCI FFR that was 0.86, as it was also published by Carlos Collet last year. We know that the threshold for post-PCI FFR depends on the vessel you are operating on. So for the LAD is around 0.86, for the RCA and the CIRC is near to 0.90. So we took the most conservative one, so because most of the vessel obviously were LAD. And so with the physiology, we were more able to achieve optimal post-PCI FFR. This was not a study aiming at demonstrating clinical benefit, but obviously the endpoint was a surrogate. But I would love to move to my second point, that is, which complexity are we talking about? We are talking about procedural complexity, and we discussed in all the cases that if we had the possibility to perform a CT with physiology, that would have been much straightforward in the management of all the cases that we saw. So the first point is that procedural complexity is not only the fact that you have, calcifications, but you need information to guide treatment. And for example, the FFR assessment, this is the case that we performed for the course in ALST last year, and we knew from the very beginning that in this case the LAD value was 0.51, that the RCA was negative and the CIRC was negative. But on top of that, as Giulio said, we knew the coronary ostia position. So we knew beforehand which catheter guiding to use, if it was needed to use a different guiding catheter than the usual one. We knew the best projection to work on. So we already knew for the proximal landing of the stent where to go in terms of projection, and for the distal landing as well. We knew the calcium. We knew where the calcium was. Was it eccentric? Was it concentric? Was it in the left main? Was it in the CIRC? Did we need to perform a 2-stent technique in case of left main treatment or not? These were all information we got before angiography. So this is crucial. In elective patient, if you want to perform complex PCI, I think that physiology on CT and all the information from CT are crucial, and because they make your life easier, basically. That's the whole point. And if we move, we will have even more information. For example, in this case, we knew the myocardial massacre risk of each side branch. So you knew if you have to protect the diagonal, if the CIRC was important or not. So in the next years, these are all information we will have on a daily basis. And on top of that, we can know beforehand what to do. So we can plan. In this case, we had 2 lesions, one in the distal left main and one in the mid LAD, and basically with the planner you can try to understand whether it's possible just to treat LAD, but in this case, as you can see, you would have ended up with the 0.80, that is not optimal for post-PCI result. In terms of treating both lesions, you will end up with around 0.87, 0.86. So for example, in this case, if you want to go with PCI, you know beforehand that you would end up treating from the LAD to the left main. And this was actually what we did. This is the angio, obviously, after the CT, and you can appreciate both lesions, so intermediate lesion in the left main and tight lesion in the mid LAD. And basically, what we did was to perform FFR, this is not the case, sorry, to perform invasive FFR, and what we reached was exactly the same result. So we stented the LAD, at the end of, after the stenting of the LAD, we had 0.80, the same exact value, and by stenting both LAD and left main, we ended up with 0.86, so very close to the predicted value from CT. Just two very short points to conclude my presentation. Another tool that can help us if you don't have CT beforehand is a microcatheter FFR, because if you have to perform complex PCI, then it can be tricky to go back and forth with the wire many times, because if you want to perform physiology, you have to perform pullback. It's not possible nowadays to perform physiology just to have a number, because if you have a pullback, you will have information about the pattern of disease. If you have a diffuse pattern of disease, no PCI will help the patient. It's not possible. Even if you put 90 millimeter of stent, you will end up with suboptimal results in terms of post-PCI FFR. So it's crucial that if you use physiology, use all physiology, so all the information that you can gather from physiology, but use it in a feasible way. So for example, this case was a bifurcation. We wanted to know whether it was necessary to go on with the diagonal, since you can see it's a little bit pinched after PCI. You see the value is the resting index from the microcatheter is 0.96, so no need to treat the side branch. Then the same for bifurcation with two stent. If you want to know whether you have to put a second stent, in this case the answer was yes, so we ended up with the two stent technique. Diffuse disease, again, the pattern is crucial. In this patient with the diffuse disease in the LAD, 84 years old, no surgical candidate, so the physiology was positive, but we decided not to treat this patient because we wouldn't be able to improve the flow in the LAD. So ostial lesion, again, because with the microcatheter, you can put down the wire, your workhorse wire, and then use the microcatheter as a balloon. So you can disengage the catheter very safely and perform your physiology assessment. Last point is patient complexity. If we have a look at, for example, the complete trial, so MI patient, non-culprit lesion of MI patient, we know that we can do it by angiography, as it was done in the complete, but this was a sub-study with QCA sub-analysis, and you can see that just by QCA, that is something that we do not actually use in clinical practice to guide our treatment, but we were able to discriminate lesions going up with events in the follow-up. But this is actually an overtreatment, because in the complete trial, all the patients received PCI, irrespectively of QCA. So the idea is that if we are able to avoid PCI in non-flow limiting lesion, that would be actually the aim of physiology. But again, how can we do it in a feasible way? I think that this is probably the only or main niche for angio-derived FFR. Why is that? Because you can perform the reconstruction on the projection you take during primary PCI. During primary PCI, you always take projection for non-culprit lesion because you want to know whether they are significant or not. So that's what we did in the AIR STEMI trial that we are performing now. We just concluded the enrollment phase, and we are trying to understand whether this approach, that is basically to perform angio-derived FFR on non-culprit lesion of a STEMI patient, is better if compared to angiography-guided PCI of non-culprit lesion. We will see. This is the results of the sub-study of the FIRE trial on angio-derived FFR system in the culprit-only arm, and you can see that QFR was able to discriminate prognosis. Again, we need dedicated trials to understand whether this is actually good or not in non-culprit lesion of STEMI patient. But the idea is that in the future, you will have to use the proper physiology for the patient you are dealing with, and in order to have the possibility to do it in a feasible way. So in my view, the non-culprit lesion of STEMI patient is a good setting for angio-derived FFR. FFR-CT is the way to go for elective patient. If you don't have CT, then use the wire, especially in Minoka and Anoka patient. Thank you very much.
Thank you for your talk and the fantastic work that you are doing in Ferrara. Any questions, any comments from Dr. Kanakakis?
Congratulations, very interesting case. If I correctly understand, the use of physiology now is not only to estimate hemodynamically significant lesions, but also to planning revascularization procedure. And in this field, you have to choose new tools for that. One of them is the PPG, pull-back pressure gradient. If you show an interesting slide, if you have diffuse disease, but it's not permitted to go for PCI in this case, only to go for statins, aspirin, etc., etc.
That's exactly the main point. So the idea is, if you use physiology, you have, as you said, look at the pattern of disease, because if you have a completely diffuse pattern, you already know that you will end up with the suboptimal result if you do PCI, even if you treat extensively the vessel. So that's the first point. And the PPG is a number telling you it's focal, it's diffuse. So it's helping you in objecting the diffuseness of disease or if it's focal. The second point is if you go with PCI, and this can be a comment on the case that we just saw, do it afterwards, because at least you know if you have done something or not. Because in that case, if you go from 0.76 to 0.81, I don't know if you have done, you know, the best job for the patient. But if you go from 0.76 to 0.86 or 0.87, we know that this is relevant for the prognosis of the patient. So that's the point. Giulio, sorry.
Before Giulio, just say that the next case is about diffuse disease, so we'll have more opportunities to discuss about diffuse disease.
I'm stopping.
Is it about diffuse disease?
Absolutely.
Okay, so let's see the next. Thank you very much, Mo. Let's see the next case then, and we'll have opportunities to discuss about diffuse disease.